So microcytic anemias, we said the MCV was less than 80. And remember, what was the etiology of a microcytic anemia? Remember, it's from impaired hemoglobin production. And so hemoglobin is made up of heme and globin. As you can tell from the name. Heme, first of all, if you look at the right, this is the heme, and then the globin are these long chains here. The heme binds to the oxygen, and the globin is a protein that surrounds and protects the heme. So, we can further divide this. Heme is made from iron and protoporphyrin. So, if you have deficiencies in iron, protoporphyrin, or problems with the globins, then you can have problems with hemoglobin production, and then you get a microcytic anemia. So the very first one we're going to talk about is iron deficiency anemia. So deficiencies in iron, and etiologies of this depend on the age a lot of times. So children and infants, they get iron deficiency from just poor intake. So breastfeeding, because human breast milk is low in iron, or it's poor diet where they're not getting very much iron in their diet. If you see an adult with iron deficiency anemia, you want to be thinking a couple of things. First of all, it's probably from bleeding. They're bleeding out, and so in the blood there's a lot of iron because they're losing all this heme, which is a lot of iron. So they're to make new blood, they have to use up more iron to make more blood. So now they're going to become deficient in iron. And so in females, what you're going to think about is menorrhagia. That's too much bleeding during the menstrual period. And then if it's a male, obviously they can't have a menstrual period, so you want to be thinking something like a peptic ulcer causing gastrointestinal bleeding. Now in an older patient, someone over 50 years old, what you want to be thinking about is colon cancer. Patient over than 50 years old with anemia, you want to be thinking colon cancer. That means it's bleeding from the cancer in the colon, and it comes out in the poop, but a lot of times you can't tell because you won't see that blood in the poop. You call it an occult GI bleed. Okay, so clinical features of this are anemia symptoms. So what did we just say? Remember, we said anemia symptoms were symptoms of poor oxygen delivery to tissues, so fatigue, shortness of breath, pallor, even angina. The other things you can get with iron deficiency anemia, pica, is very characteristic. So as patients, they're eating non-food items, so like ice, they eat dirt, they eat hair. You see someone eating ice or like dirt or something, you want to be thinking pica, you want to be thinking iron deficiency anemia. And then finally you have colonychia, that's spooning of the fingernails. So I'm going to zoom in here. You can see here it looks like a spoon. See that indentation, that dip? Think about that, that's a spoon right there, a spooning of the fingernails. So that's also characteristic of iron deficiency anemia. So anemia symptoms, pica is very characteristic, colonychia is very characteristic. Lab values, what you're going to see, and I'm going to explain this in a second, is decreased ferritin, increased TIBC, that's total iron binding capacity. Total iron binding capacity. You're also going to see microcytic red blood cells, which we just talked about, and you're going to see central pallor, that's in iron deficiency anemia, central pallor. So what the heck is ferritin, what the heck is TIBC? First, to understand that, we have to understand iron absorption. So first of all, you take iron, so you take it in the food, it's in the small intestine, and then your enterocyte's going to take it in, and take it in through this transporter called ferroportin. Once the iron gets in the blood, it's bound to transferrin. Transferrin binds the iron and helps move around in the blood. Transferrin takes the iron and moves it to different parts of the body. Delivers it to the liver and to the bone marrow for storage. So once you get this iron to the liver, it's going to be taken in, and it's going to be stored, and it's going to be stored in the form of bound to ferritin. Okay, so the more iron you have, the more iron gets stored, and you need more ferritin. You have increased ferritin with more iron. And then, so in this case, we have less iron, so you have less ferritin because you don't need much ferritin to store it. And then, what about TIBC? What the heck is TIBC? So that's the stuff that binds iron. So remember, transferrin binds iron, and then we use TIBC, total iron binding capacity, as a surrogate, as an indirect measure of transferrin, because there's other things that can bind iron in the blood, but transferrin is the main one. Okay, and why would we have increased transferrin or increased TIBC in an iron deficiency anemia? Because it's your body senses there's low iron. The cells in your body, all throughout your body, are not getting enough iron. So you're going to upregulate transferrin in the hopes of being able to move more iron throughout the body. So ferritin goes down, TIBC goes up. And honestly, the easiest way to remember this to me is just remember they always go opposite. Wherever ferritin goes, TIBC will go opposite. So you have to understand one of them, how one of them react, and then the other one because it's going to be opposite. So that's it for iron deficiency anemia. Again, etiologies depend on the age group: children, diet; adults 20 to 50 is bleeding from menorrhagia or peptic ulcer; older adults, colon cancer. Clinical features: chloronychia, pica, and then these lab values are going to help tell you a lot. You see that central pallor, decreased ferritin, increased TIBC. Now, next one is thalassemias. Thalassemias are problems, inherited defects in synthesis of globin chains in the hemoglobin, and so you've poor hemoglobin production, you get anemia. Okay, so the problem here is here in the globin chains. So you can get problems in either the alpha chain or the beta chains of the hemoglobin. Let me go back here. Remember that there's an alpha chain and there's a beta chain in adult hemoglobin. So you can get defects in either. You get alpha-thalassemia and a defect of alpha chain, beta-thalassemia and defects of beta chain synthesis. Now I want to add there's other types of hemoglobin that you can have. When we are neonates or in the fetus, they have something called hemoglobin F. That's for fetal hemoglobin. This one is made up of alpha chains and the gamma chains. And then the other one we can have is, so hemoglobin A is for, A stands for adult. You can have hemoglobin A2. That's made of an alpha chain and a delta chain. So remember, there's always an alpha chain, but then the second chain can differ. Now, alpha-thalassemia. There are normally 4 copies of the gene that codes for alpha hemoglobin on chromosome 16. There's two copies on each chromosome. So, alpha-thalassemia arises due to inherited deletions in these genes. And so, the other thing you want to know is alpha-thalassemia is associated with Asians and Africans. So that's easy. At least they all start with A. So now, if you get one single deletion, so I want to just draw this out. You have 2 chromosomes, you get alpha 1, and then you have 4 genes. If you lose one of these genes, you get, it's a single deletion. This is asymptomatic. You have enough genes making alpha globin, the alpha globin chain, that you're gonna be making enough red blood cells. You're gonna be asymptomatic. Now, if you have 2 deletions, you can either have, first of all, you get a mild anemia because you have reduced alpha globin production. Now you can either have a cyst deletion or a trans deletion. And what does that mean? So a cyst deletion, remember, a cyst means it's on the same side. So let's go back. So again, we're at the cyst deletion. So we lost this one, and if it's the same side, same chromosome, that's a cyst deletion. And Asians are at risk of having a cyst deletion, and Africans then are at risk of a trans deletion. So that's the opposite. So you lose this one and you lose this one. So one copy on each chromosome is lost. Africans are at risk for that. And the difference is that cyst deletions have worse outcomes for the carrier's offspring. If you want to think about it, because the offspring, if you're gonna let's say transmit it to your offspring, if you are an Asian, you have a cyst deletion, you transmit this one to your offspring. Your offspring automatically has at least 2 gene deletion. Whereas this one, you transmit it to the offspring. At worst, they have only a single. They might only just have a single deletion. They might become asymptomatic. So that's why your cyst deletions can be worse. Now, if you have 3 alpha genes deleted, you get moderate to severe anemia. So it's very simple: asymptomatic, mild anemia, moderate to severe. And the problem here is now you don't have enough alpha chains. You have too many beta chains because they're not combining to make hemoglobin. These beta chains are just hanging around. They're going to form tetramers. They're going to join together, form tetramers, and they're going to make something called hemoglobin H. And this hemoglobin H can go damage red blood cells. You don't want too much of this hemoglobin H. Finally, if you have 4 alpha genes deleted, you're in big trouble. You have no alpha genes at all. Remember that in the fetus, you normally make hemoglobin F, but you're not making that, so you have too many delta chains hanging around. So these guys are going to hang around too much. They're going to form tetramers, and you're going to get something called hemoglobin Barts, HB Barts. And same idea as HBH. You get damage to red blood cells with HB Barts, and this is incompatible with life. And the other thing you'll see is you see Hydrops Fetalis, which I told you about. What was Hydrops Fetalis? Remember, it's the buildup of fluid in multiple fluid compartments in the fetus. And again, why did that happen? It happens because you're not making red blood cells. You're getting poor oxygen delivery to the body. Your heart is going to be working extra hard to compensate, at least in the fetus. And the heart's going to work so hard it's going to fail. And then you're going to get baggage up of fluid. You're going to get fluid buildup in different parts of the compartments of the fetus body. So that's it for alpha-thalassemia. Next, we're going to go to beta-thalassemia. This is the problem in point mutations in the beta chain gene. So again, there's two copies of the beta chain gene in comparison to alpha, which had 4 copies. This one is common in the Mediterranean populations. Okay. Remember that the alpha chain mutation was common in the Asian and the African, which was easy. So this is the one. This is the Mediterranean. So beta thalassemia minor arises in a heterozygote, so only one chain mutation, the mutation in one of the genes, and you get underproduction of the beta gene. This is usually asymptomatic, but you can diagnose this if they have increased hemoglobin A2. So if they have less hemoglobin, they have less beta chain, so they're not making as much hemoglobin A. Remember that's from the alpha beta, so they're going to get more hemoglobin A2, which is alpha delta. Now you have hemoglobin beta thalassemia major. That occurs when you have mutations in both the genes. Each copy has a mutation. You have a homozygote, and there is no beta chain production. So you can get severe anemia a few months after birth. Because why would it be after birth a few months later? Because first of all, during birth and in the fetus, you have a lot of hemoglobin F. That's the fetal hemoglobin, so that's protective. But eventually, that's going to die down, and you would expect to have production of hemoglobin A, but now you're not producing any beta chains. You're not getting hemoglobin A. You get severe anemia, and so you're also going to get too many alpha chains, so they're going to aggregate and they're going to damage your blood cells, similar to how HBH does it, hemoglobin Barth does it, and so you get too much alpha chains here, you get damage. Now, in an effort to correct the anemia, I just told you there's severe anemia a few months after birth. To correct it, your bone marrow is going to work extra hard. It's going to get bone marrow expansion. And you're also going to try to make more hemoglobin, more red blood cells extramedularly. That's in the liver and the spleen. You can also make red blood cells. So what happens with these is you're going to get bone marrow expansion. What's going to happen is you get expansion in the skull and the facial bones especially. And then so on the x-ray, you're going to get a crew cut appearance. That's from your bone marrow, your bones in the skull just expanding and getting bigger. So it looks like a crew cut appearance. You can Google that. Or you can get chipmunk faces. This is it. This is the facial bones expanding. And this kid looks like a chipmunk because his facial bones are enlarged, because the bone marrow is working extra hard and trying to make more red blood cells. So that's it for the bone marrow expansion. Now if you have extramedullary hematopoiesis, what happens is you get enlargement of those organs. So I told you it's the liver and the spleen, so you can get hepatosplenomegaly, and you're also at risk of a parvovirus-induced aplastic crisis. So that's where the bone marrow fails to make blood cells. So patients with beta thalassemia major are, when they get a parvovirus infection, they're at risk of aplastic crisis. Now these patients, they have severe anemia. The way you treat it, you have to give them chronic transfusions. You give them red blood cells because they're having problems making their own, so you give them transfusions for the anemia. However, you're giving so much transfusions, you can risk iron overload, and you can get secondary hemochromatosis. Because each pack of that red blood cells you're giving them has a ton of iron, a lot more iron than you would normally ingest. And so you're overloading with them with iron. You get secondary hemochromatosis. Remember, what was the triad of hemochromatosis? It's a little bit of a throwback, a little bit of a link. Remember, this is the bronze diabetes. So you can get the diabetes, you get bronzing of the skin from the iron deposition, and you also get liver failure. And then on the labs, you're not making hemoglobin A because you have no beta chains. So instead, you're going to have elevated hemoglobin F, fetal hemoglobin, or in hemoglobin A2 because you have delta chains and you still have gamma chains, and your alpha chains are fine. So next is sideroblastic anemia. This one is a problem from defect in heme synthesis. And this right here is a chart of how we make heme. We start with glycine and succinyl-CoA. You don't have to memorize this. Just memorize a few of the things. I'll tell you what to memorize. So the problem here is you can have a defect in the ALA synthase enzyme. So ALA synthase takes your glycine and succinyl-CoA and makes ALA. You can have a defect in alcohol, which damages the mitochondria. As you can see, this all is occurring in the mitochondria, goes out into the cytoplasm, and then ends up back in the mitochondria to get heme. So a defect in mitochondria you get from the alcohol. Or finally, a vitamin B6 deficiency. As you can see here, vitamin B6 is a cofactor for this reaction. So defect in the ALAS gene, alcohol, or vitamin B6 can cause a sideroblastic anemia. Now, clinical features here, you can get ringed sideroblast, and this is a ringed sideroblast. You can see a big ring of this stuff that stains blue. The reason you get this is because we get iron in the mitochondria. The iron's there for incorporation to make heme. But if you have a defect here in sideroblastic anemia, you're not getting any protoporphyrin, so you have none of this stuff. So there's nothing for the iron to combine with. So it's just going to accumulate in the mitochondria. You're going to get a bunch of iron. And so you're going to get mitochondria that are filled with iron. They're going to form a ring around the nucleus of the red blood cell precursor. And so that's why you get this staining, this ringed sideroblast appearance. So these cells here are called sideroblasts. That's why you get ringed sideroblast. Now, what lab findings would you get? What levels of ferritin and TIBC would you have? I told you ferritin helps you store iron in the liver cells. So if would you have more or less iron in this disease? I just told you have a buildup of iron, so you have too much iron, so you're going to get more storage of iron in liver cells, you're going to have increased ferritin. So what's going to happen to your TIBC levels? Your TIBC levels are going to be decreased. And this makes sense because iron can be used by bad stuff in your body, including bacteria. They can use it. So you want to decrease your sending to. You don't want too much iron delivered to all the bad stuff, the bacteria in your body. So you want to decrease the stuff that transport iron when you have too much of it. So again, just to recap the sideroblastic anemias, defect in heme synthesis, especially right here in this box. So the things can be a defect in the synthase enzyme, defect and not enough vitamin B6, and then finally alcohol. And I just want to add one more thing. Vitamin B6 deficiency. Do you remember how you can get a vitamin B6 deficiency? I'm thinking about a side effect of a drug specifically, and especially it's a drug for an infection. That would be isoniazid. Isoniazid can get you a vitamin B6 deficiency. And for clinical features, you get these ringed sideroblasts from the iron accumulation in mitochondria, and then these lab features you should be able to intuit. Finally, we can get lead poisoning can cause microcytic anemia because lead inhibits this step right here of heme synthesis as well as this step. So you have impaired heme synthesis, and the other thing it does, iron, is it inhibits rRNA breakdown in red blood cells. So you get retention of rRNA aggregates and you get basophilic stippling. So this is a characteristic feature of lead poisoning, this basophilic stippling in red blood cells. So erythrocyte stippling is another word for that. Now, clinical features of this, we have a nice mnemonic for this. You can get lead lines, as you can see here, this darkening of the gums. And the E is for encephalopathy, so just altered mental status. The brain's there's a damage to the brain. The brain's not functioning well. They're confused, altered mental status. And then you can also have, again, the stippling. And the A stands for severe abdominal pain. And finally, the D is for wrist and foot drop. So treatment for this, you have to chelate the lead. You want to chelate it so that they bind to the lead and you pee it out. So for kids, it's succimer. For adults, it's dimercaprol plus or minus EDTA. The way I remember succimer for kids is, kids often get opson seizures. And what was the treatment for the opson seizures? Remember, the treatment was ethosuximide. And the reason why I say this helps me remember is this sucks. Ethosuximide for opson seizures, succimer for kids with lead poisoning. And again, adults, dimercaprol plus or minus EDTA. So that's it for lead poisoning. Just remember that mnemonic, lead. Lead lines, encephalopathy, abdominal pain, wrist and foot drop. I think especially this abdominal pain, neurologic symptoms, foot drop, wrist drop. That's very characteristic of lead poisoning. And that's due to inhibition of ALAD. That's the ALA dehydratase, or inhibition of ferrochelatase. So that's it for our microcytic anemias. Again, what were the 4 microcytic anemias we talked about? Iron deficiency anemia, which is problem in the production of the heme. You have Thalassemias, which are problems in production of the globin. You have the sideroblastic anemia, which is another production of heme problem. And then finally, lead poisoning. Again, you have a problem with the production of heme. So that is it for microcytic anemias.